and to share with you some thoughts about the management of pulmonary involvement in patients with hematological malignancies. We are dealing with a phenomenon that is frequent. It is believed to complicate about 1% of patients with solid tumors and up to 20% of patients with hematological malignancies. And it can be 1 every 4 patients who is recipients of allogeneic bone marrow transplantation or stem cell transplantation. It's a severe disease with a 50% mortality, and the outcomes today are still related to the need of mechanical ventilation, with some recent benefits from non-invasive ventilation and from non-invasive diagnostic strategies. If the etiology of the respiratory involvement is not known, there is an increased mortality, and we are going to focus on this today. And in the intensive care unit, infection is the rule, and we can understand that 90% of our patients are getting any antimicrobial agent, but some patients come to the ICU for non-infectious pulmonary involvement. In patients who are with neutropenia or bone marrow transplantation, we can consider that the respiratory events occur in 40 to 50% of the cases, and half these cases come to the ICU, so we can expect about 25% of patients coming to the ICUs for acute respiratory failure. This is the experience in my institution, where we have a ward for every specific malignancy, one for CML, one for acute leukemia, myeloma, lymphoma, chronic lymphocytic leukemia, Hodgkin disease, various and miscellaneous hematological malignancies, but also 2 distinct wards for lung cancer and breast cancer. And as you can see, the number of patients coming to the ICU is very low in patients with solid tumors, and it's about 12% in patients with aggressive malignancies. Overall, mortality is 50%. Something that is interesting is to understand better why it is a problem. And I like very much this paper from Puig, published in Leukemia and Lymphoma about 5 years ago, and it's on patients receiving autologous bone marrow transplantation. And you can see that the incidence of respiratory event is 15%. It comes in general 11 days after the transplant, and it is interesting to understand that it's at the time of neutropenia recovery. And 2 risk factors are independent, and myeloma patients and patients with neutropenia are at a very high risk of respiratory events, and the mortality is 8% in patients with no respiratory events and 50% in patients with respiratory events. And one of the strengths of this paper is that they show that mortality is also increased because the classic hematological management cannot be done in patients in the ICU with mechanical ventilation and other organ dysfunction. This is another way to quantify the events. A very nice paper published 2 years ago in bone marrow transplantation, and it reports about the infectious complication in patients who received either chemotherapy for induction of an acute leukemia or allogeneic BMT. And as you can see, you compare chemotherapy, allogeneic BMT, and you can see that bloodstream infections occur in about 27% of the cases, and pneumonia is the other great complication of cancer therapy and BMT, occurring in about 27% of the cases. And another way to say the things is that per 1,000 days of neutropenia, the risk of pneumonia is 15 per 1,000 in patients receiving chemotherapy and 12 per 1,000 in recipients of allogeneic BMTs. And of course, the longer is neutropenia, the higher is the respiratory event and the bloodstream infections in patients receiving either chemotherapy or BMT. So to go into the lungs of these patients, we need to focus very clearly on the goals of our strategy. First, if you are thinking that everyone is at risk of everything, you will fail. And this is the case sometimes. You are receiving a patient to the ICU, receiving any kind of anti-infectious agent for covering every disease, but the right disease is not known, and you are paying with the toxicity of every agent. And before getting into any strategy, you need to think about what is the diagnosis, or maybe sometimes what are the two likely diagnoses in your patient. So before any investigation, you need to understand a pretest probability of a diagnosis. And for example, you are sitting on the chart, going into the clinics and examining the patient and saying, well, it looks like a PCP, a Pneumocystis Pneumonia, and maybe a viral infection could also do it, and these are my two diagnoses. Or you say, well, it's a bacterial infection, but I cannot rule out fungal infection. So at the end of a process, you need to have one or two diagnoses. Then you have a pretest probability, but then you need to determine the best investigation adapted to the patient, to the topography of the lung involvement, to the severity and hypoxemia, to say, well, now I'm going to confirm my feeling and to go into the real diagnosis. And even if we are very much non-invasive, we need to keep the history open and agree that sometimes we need to be very aggressive doing strange things, and this will be my last slides. So it's 11 evening, and a patient comes from the hemato wards. It's day 20 from an acute leukemia, and he has an acute respiratory failure. And of course, you need to do these three things at the same time. You need to analyze the chart and to understand the risk. Every patient has a different risk regarding bacterial infection, fungal infection, PCP, or any other infection. You need to resuscitate the patient, and you know that it takes a long time. And of course, if you are very clever and smart and you are very good at understanding what the patient has, but you can fail to increase oxygenation or to improve septic shock, you are going to lose at the end. But even if in the morning you pass us a patient with a good analysis, a patient who is living and in a good condition, we need to do something to confirm the diagnosis. If you say, well, I think this is a bacterial infection, and he is very well under non-invasive ventilation, well, you need to do something to confirm that it is a bacterial infection, or at least to exclude some important overdiagnosis as to make it very simple and safe. So one of the different strategies that you could use is to use the direct strategy. The direct strategy is the patient has just come to the ICU, he is well under non-invasive ventilation, and you can expect that you are going to pass about 1 to 2 minutes per days of disease. So if you have a patient with 20 days of acute leukemia with many events, 10 times fever, different antibiotics, it can take you 2 hours to understand all the chart. But you need to spend the time. And another way to keep some time is to say, well, from my chart, I'm going to extract the direct. D is the time, the delay, since the diagnosis of the malignancy or the BMT or the different antibiotic strategies that have been recently implemented. I is the pattern of immune deficiency. Of course, a patient with acute myeloid leukemia has almost no risk for Pneumocystis pneumonia within the first months of the disease. A patient with acute lymphoid leukemia or with a lymphoma or with a CLL, a chronic lymphocytic leukemia, can have a Pneumocystis pneumonia without any treatment just because of the immune deficiency related to the malignancy. You have the radiographic appearance, the clinical experience, and we as intensivists, we know that when a patient in 2 hours becomes very sick with high fever, acute respiratory failure, and shock, it is likely to be a bacterial infection, but sometimes it can be something else. You have the clinical picture, and you have the T for the high resolution CT scan. So using the direct attitude, sometimes you can very much gain time and understand better what is the diagnosis. Let me give you some examples. This is an acute leukemia, and if you take the day 0 of the diagnosis until all the treatment phase, treatment initiation, neutropenia, consolidation therapy, late phase, different diagnoses may come. For example, when the patient comes to the ICU with an acute myeloid leukemia, it can be infectious, of course, but my experience in more than 200, 300 patients with this case is that it's mostly the involvement of the leukemia in the lungs. And you have different forms, and we are going to see that. When you are beginning the chemotherapy, you may have a lysis syndrome, which is like with the kidneys, it's a tumor lysis syndrome, and you have a blast burden into the lungs with the endothelia creating alveolar hemorrhage, and this is exactly linked to the burden of the leukemia into the lungs. During neutropenia, it's in most of the case bacterial sepsis, but according to the duration of neutropenia, it can be fungal. According to the country where you live, it can be histoplasma, tuberculosis, toxo, it depends on the cases. And during the consolidation therapy, it's mostly toxicity from pulmonary or cardiac toxicity from the cancer chemotherapy. When you have a patient with acute leukemia and lung involvement, you must think to leukemic infiltrates. And you have three different types of leukemic infiltrates. One is quantitative. Leukostasis, you have a huge number of blasts circulating, and they are going into the lungs, 50,000, 100,000 of blast cells circulating, and this will create a rapidly growing hyperleukocytic acute myeloid leukemia, and these patients can have emergency chemotherapy to decrease the number of circulating blasts, and in general, when you are below 50,000, they are going to improve, and it will be easier for them. Another way to have pulmonary infiltration by the leukemia is not quantitative, it is qualitative. And for example, the leukemic pulmonary infiltrates, it's not that you have a large number of blast cells circulating, is that you have typical blast cells that are monoblasts for the M4 or the M5 subtypes of AML, and these monoblasts have a specific affinity for the pulmonary endothelia. And this is not quantitative, this is qualitative, and in this case, you may use the steroids because it decreases the adhesion of the blast cells to the pulmonary endothelia. And when you are beginning chemotherapy, 12 to 24 hours after the onset of chemotherapy, you can have lysis pneumopathy, which is a pure alveolar hemorrhage, a diffuse alveolar hemorrhage. Of course, this is not like vasculitis in patients with immune disease. This is not like in BAPT patients with capillaritis. This is only pulmonary toxicity of the blast burden into the lungs. And this is diffuse alveolar damage. Give you an example. These patients came to the ICU, a 57-year-old patient with no previous medical history, coming to the ICU for severe hypoxemia and crackles in the lungs, but as you can see here, no real types of bacterial pneumonia. And as you are taking charge of the patient, the lab is calling you saying, well, in the marrow smears and in the blood, I can see blast cells. And this patient has 5,000 leukocytes, not a lot. But these very specific cells, like the pulmonary endothelia, and they are going to create huge pulmonary infiltration with hypoxemia. If we are using the CT, you can see that it's very different than bacterial pneumonia. You don't have alveolar consolidation. You can see here that the septal lines are full of blast cells, and this is typical. You could have almost the same pictures in patients with acute pulmonary edema from cardiac insufficiency. But here it's not salt and water, it's blast cells. And the best you can do here is to provide chemotherapy and steroids as to decrease pulmonary adhesion. And when the patients are going to have 1,000 or less leukocytes and becoming neutropenic, they are going to recover, and you will be able to stop the steroids and to go into the pure chemotherapy and the patient management. A few years ago, let's say 20 years ago, we were performing BL, but we are not longer performing BL because the CT is telling us enough. And in the BL, we were finding these blast cells full of hemorrhage, but we are not doing this anyway. We are only going into chemotherapy non-invasive ventilation or intubation if it's needed, and decreasing the number of blast cells until neutropenia. The I of the direct attitude is about the immune deficiency. And every time we are taking in charge a patient with hematological malignancies, we are saying, well, what is the disease? Is it from the phagocyte, from the lymphocyte, from the B cells, from the T cells, from the neutrophils? And according to your disease, you are going to have different diagnoses. To go into an example, myeloma. Myeloma 20 years ago was a typical disease for bacterial infection, and in most of the case from pneumococcal disease. And this is still true. We still have pneumococcal disease related to myeloma because there is an impairment of neutrophils and there is an increased risk for bacteria. But now in the same disease, we are using targeted therapy like thalidomide, bortezomib, lenalidomide. We are using bone marrow transplantation. And we know that we are going to increase the stimulation of T cells, of NK cells, of dendritic cells, and we are looking more and more patients with viral infections, with different infections, like, for example, multiple resistant bacteria, because myeloma patients used to live 18 months, and now they are living 10 years. So to the gain increase in survival, you are facing different risk for multiple resistant bacteria. But also never forget that patients receiving thalidomide are at high risk of pulmonary disease such as thromboembolism, because thalidomide is increasing the risk for pulmonary embolism and deep venous thrombosis. Another thing using, again, targeted therapy is when we are using anti-CD52 and alemtuzumab, which is used in T-cell lymphoma and in very specific disease. We know from the literature that we have an increased risk of fungal and parasitic infections, and we know that we need to target this. Let me give you another example. This patient came to the ICU. It was Friday, 4 p.m. And the patient had no previous history, 43 years old, and at the time you are evaluating him, you learn from the lab and from your colleagues from the hemato department that he has a hairy cell leukemia. It is an acute leukemia, but this type of leukemia can be cured with only one administration of chemotherapy, which is not pure chemotherapy, but targeted chemotherapy with very, very few side effects. One of the side effects of the chemotherapy is allergy, and many kinds of allergy have been described. But these patients come to the ICU before any chemotherapy because eventually he has a complication of the immune deficiency related to the hairy cell leukemia. So let me go back to my ID slide. Is it the phagocyte? Is this the neutrophil? The lymphocytes? What's the problem with hairy cell leukemia? The problem with hairy cell leukemia is monocyte and macrophages. And we know that these patients have a very, very specific immune defect regarding every intracellular bacteria. And of course, you should do a BL because this is what is recommended. But we are never doing BL. Antigenuria is going to disclose that this is a legionellosis, and we are only going to treat the patient based on non-invasive diagnostic tests. The patient is going to cure very, very easily, and no invasive strategy has been underwent, only because we know that the patient has a very specific immune defect. And it's, in general, intracellular bacteria. It can be tuberculosis, it can be mycoplasma disease, it can be Aspergillosis or any mucoral disease, because these patients are some of the time coming to the hospital very, very late after the onset of the disease. The same patient, it's not the same patient, but the same disease, patient with hairy cell leukemia, comes to the ICU at day 21 after having received the chemotherapy, this very targeted chemotherapy, which has one of the main side effects, allergy. So you can see the same disease, but this time you can see that this is an infiltrative disease with ill-defined nodules and alveolar consolidation. And this is one of the cases where you think that there is a drug-related pulmonary toxicity. And this is very important because you are going to say, well, your patient is allergic to a medication that is increasing his life with 30 years of benefits. So you are doing a BL, and it's full of eosinophiles, and indeed, it's a drug-related pulmonary toxicity, but we are not going to stop the drug. We are going to administer the drug along with some doses of steroids, and the patient is going to be cured and to have a high chance of surviving. So how do you think that this chest X-ray is so specific? We know that we have a pulmonary involvement. There is a syndrome that involves both lungs, and no one of us can say, well, this is this diagnosis. We need to go and to have more information about the patient. And I'm sure that everyone here says that this chest X-ray is normal. And it is normal, only for one reason, is that chest X-ray is not sensitive in patients with neutropenia. The CT that is done at exactly the same time shows this very hard consolidation, and it's only saying that patients with neutropenia may have 12 hours delay in their ability to have images on the chest X-ray. So you can expect it's very much cheaper, and after 12 hours you redo the chest X-ray, or you can, if you want really to understand, have a CT at the same time showing that chest X-ray is not sensitive. And chest X-ray is not specific because as an intensivist, I'm very happy that the patient is already intubated, but it's the only thing I can say. I can tell you that it's Pneumocystis Pneumonia. I can tell you that it's cardiac pulmonary edema or an Aspergillosis. I have no idea. I need to enter into the file and to better understand the patient to go into an invasive or a non-invasive diagnostic strategy. The CT, which is the T of the direct attitude, is also very much useful in this patient when it can be done, when the patient are not very sick, not very shocked, when they are not under 100% FiO2. You can have a very nice evaluation of the CT as it is done with a pulmonary disease, chronic pulmonary infiltrations of the interstitia. And you must quote if there is a ground glass opacities, from no ground glass opacities to important ground glass opacities, consolidation, nodules, linear septal lines, as we've seen for the patients with pulmonary leukemia, cavitation, and effusion. And of course, you can see that every one of these symptoms and of these patterns is very poor, and you cannot use it because it's very, very weak to make a diagnosis. But if I tell you that I have a patient with a CLL, a lymphoproliferative disease that is very much a risk for viral infection and pneumocystis infection, and then I tell you that he has received fludarabine, he was allergic to Bactrim, to cotrimoxazole, with no ability to have a prevention for pneumocystis, and he has a diffuse ground glass opacities with some linear opacities and no effusion. Well, my pretest probability of pneumocystis is so high that every negative test will not convince me. But a very simple positive test will convince me. And for example, we are going to do an induced sputa, and on the induced sputa, we are going to do PCR because we know that it is a very simple way to make the diagnosis. And a very specific pattern of disease can help to make a diagnosis. But a same picture can be related to different things according to the clinics. And we have here central lobular nodules. These nodules are topographically indicating that you have a bronchiolitis. And in this case, it's a heavy smoker patient undergoing BMT, and you can see here the huge emphysema and the pulmonary disease. And this disease is with a high fever, it's very acute, and the patient has very important sputa, and you are only examining the sputa. It's full of Haemophilus influenzae, and you have nothing else to do than treating the patients with a very simple antibiotics. And now we are only giving amoxicillin to these patients because the beta-lactamase rate in Haemophilus have very much decreased in Europe, and the patient is going to be cured after a very simple antibiotics. No antifungal, no broad spectrum antibiotics, nothing. Another example, this is a 70 years old girl, a recipient of BMT, of allogenic BMT, after 11 months. And as you can see, she has a very, very severe and hypoxemic disease. and the disease is related to parainfluenza virus, the number 3, which has been isolated from the nasopharyngeal respirate, only non-invasive, and we are providing ECMO to this patient because she was very hypoxemic, and she didn't receive any antibiotics because everything was negative, and she cured after a very simple management. And in this case, it's a patient coming to the ICU for an acute tumor lysis syndrome with a kidney insufficiency, an acute kidney injury. And he had no oxygen. And very easily, the CT showed these nodules. And since the patient was not hypoxemic, we performed a BAL. And on the BAL, there was a huge number of lymphocytes. And it was very easy to type the lymphocytes and to see that it was a pulmonary involvement by the T lymphoma. Of course, if you are using CT, you may be aware that the halo sign, this sign of a subpleural nodule with a ground glass opacity surrounding the nodule, is very, very informative about the risk and the presence of fungal disease, mostly Aspergillosis. But we know that this halo sign can be seen in many, many diseases. As you can see here again, the nodule in the subpleural domain with ground glass opacities, and this is the infectious infraction, and this is the hemorrhage surrounding the nodule, and this is very typical of fungal disease. It's very transient, only during the neutropenia recovery time, but it can be seen in many diseases also. As you can see here, this is the infraction with the necrosis, and this is the hemorrhage surrounding the nodule and giving the feeling of ground glass opacities. But these diseases can be seen in many, many, many different situations. Infections or non-infection. It can be CMV. It can be septic emboli. It can be a parasite. But in a patient with a high risk of Aspergillosis, you can consider that having a halo sign is a sign that should perceive you to treat the patient using voriconazole. This is also a halo sign, but this is a mucorale. This is not an Aspergillosis in patients with acute leukemia. Another example to use the CT is that these patients have very common points. They are all hypoxemic, and they are in the ICU with lymphoproliferative disorders. They are receiving long-term steroids plus fludarabine. Fludarabine is an experimental model of Pneumocystis Pneumonia. They have inadequate PCP prophylaxis. They have a subacute acute respiratory failure. It's not in 1 day, it's in 5 to 7 days, and no other organ dysfunction, no septic shock. And look at the CT profile. You can see ground glass opacities, diffuse in both lungs. And if you are looking here, you can see that the cortex of the lung is almost normal. You have here the opacities, but here you have all of the time, you have something that is clearer in the cortex of the lung. And this should be something that you should think on it. And this is increasing very much the likelihood of pneumocystis, telling you that your patient should receive cotrimoxazole during the night, and then the day after, you will do an invasive induced sputa or non-invasive BL test to make the diagnosis. This is another very specific type of pulmonary infiltration with alveolar proteinosis. It is a non-infectious disease related to a problem with the surfactant and the SPB protein in patients with myeloid leukemia, mostly chronic myeloid leukemia, but sometimes acute myeloid leukemia. So the problem, and to finish this first part, is that if the patient is not with a definite diagnosis, and if after your evaluation you are not able to identify and determine the etiology of pulmonary involvement, the risk for dying is very high. So you need to do everything to confirm your first approach and to go into the diagnosis. And this case is very much, I would say, an index case for me, because this patient has changed a lot of the way we are dealing with this story. It's a 60-year-old patient with a Hodgkin disease, and he has received 7 cures of chemotherapy. And the hemato says, well, no, it's okay. He's cured. He's in complete remission. But he has an acute respiratory failure, and it's with no septic shock, with almost nothing else than a very diffuse pulmonary involvement, and a quick need for intubation. And this patient will have 3 BLs, everything is negative, 7 search for tuberculosis, it was negative, and everything was negative. He died after 2 weeks of ICU, and 5 weeks after, the cultures for tuberculosis grew positive. And look at this very strange, this is the post-mortem pulmonary biopsy, this very strange tuberculosis involving the lung in a patient who is cured for Hodgkin disease, who had nothing before chemotherapy, and who died with everything negative, but came back positive 5 weeks after ICU management and death. So to make the diagnosis, you can choose between an invasive or non-invasive diagnostic strategy. Invasive, a few years ago, it was the pulmonary biopsy. But it's in patients with severe hypoxemia, deep thrombocytopenia, it's a problem. So in the late 80s and the early 90s, bronchoscopy and BAL replaced the pulmonary biopsy, and it provided some diagnosis in about half the cases, and in half the cases it was very difficult. And we have non-invasive tests, blood cultures, sputa examination, induced sputa, nasopharyngeal aspirates, antigens, chest echography, and CTs. And we are going to compare the BAL to all these non-invasive tests. As you can see, some are culture-based, like the blood, the sputa, and the BAL, and some are non-culture-based, based on the CTs, the galactomannan, which is more molecular, the PCR, and the beta-D glucan that can be used for non-invasive diagnostic of fungal disease. And of course, if I'm trying to convince you that we are dealing with a CMV pneumonia, you must find CMV, otherwise you are not going to believe me. You must find CMV here, Aspergillosis here, RSV here, herpes here, and the problem with this kind of disease is that if you want to have an infectious diagnosis, you must have a positive test. Otherwise, you are not able to say, well, it's CMV, it's herpes, or it's RSV. This is a paper from the person in the world that I'm convinced he knows well the story than everyone else. His name is Bekele Afesa. He works in Rochester at the Mayo Clinic. He has been trained in Greece. He is from Ethiopia. And he is the person, I think, the most powerful in this kind of disease. His group has provided this very simple study comparing the clinical data before and after autopsy findings in patients receiving BMT. And before the autopsy, 28% only of the patients had the right diagnosis. When we are performing autopsy, you can find that what was on the BAL, bacteria, Aspergillosis, alveolar hemorrhage, were not treated because autopsy showed that the patient had Aspergillosis, but BL was negative. Autopsy showed that there was a bacterial pneumonia, but autopsy was negative. And autopsy showed that there was an alveolar hemorrhage, but BL was negative. And some patients had things on the BL that was not confirmed on the autopsy. And it was Aspergillosis, that was only colonization, CMV colonization, bacterial, and even alveolar hemorrhage on bronchoalveolar lavage that was not met during the autopsy, showing very clearly that all what we have, if we take the autopsy as the gold standard, in more than 60% of the case, we are really failing. Look at the results of the evaluation of BL. In about half the cases, BL will provide with the diagnosis, and in 1/3 of the cases, you will have a therapeutic impact of BL. And this is, of course, very much underestimated because none of these studies report on the bronchial observations during bronchoscopy. And this patient, who is a recipient of BMT, but could be also a recipient of lung transplantation, because we can see that had a tracheobronchitis with Aspergillosis, and this is positive. You can take this, and the smear is full of Aspergillosis, but the BL here is negative, because this disease is an airway invasive disease. This is not a disease of the alveoli. And of course, what is taken from the bronchial will be positive, and what is taken from the alveoli is negative. And a certain number of years ago, a team from Barcelona have shown that some of the non-invasive tests have also a good efficiency, like blood cultures that are positive in 17% of the cases, galactomannan, CMV, nasopharyngeal wash, sputum examination, bronchial aspirates, PSDP, transbronchial biopsy, or open lung biopsy can also be done. But using only non-invasive tests, you can have a diagnosis also in about half the cases. Let me give you an example of a very simple non-invasive management. This is day 20 of neutropenia for a patient with acute myeloid leukemia. And he has a very sudden chest pain. Of course, chest pain, if the electrocardiogram is normal, if there is no sinful pulmonary embolism, chest pain in a patient who is neutropenic is a sign of pulmonary infarction, but not from a DVT, not from deep venous thrombosis, but from aspergillosis. It is a very rare sign. This is what is called the chest pain, infectious chest pain. And this patient has indeed an infarction, and the sputa is full of aspergillosis. A very simple sputa. If you are using the EORTC criteria, you have a host factor, you have a pulmonary factor, you have a microbial factor, and 2 days after, because it was Saturday night, the galactomannan came back positive, and your diagnosis is made. You need nothing else to make a diagnosis of possible or probable putative invasive pulmonary aspergillosis. But this case of using galactomannan may be different across different type of pulmonary aspergillosis. This is airway invasive aspergillosis in a patient who is not neutropenic. And this is a patient who is neutropenic with the halo sign. This is a vascular infarction with a halo sign. And this galactomannan will be positive. And this is airway invasive with central-lobular nodules. And you have more chance to have a sputa that will be positive in this case. And indeed, you have two different types of disease. And this has just published in Blood by a team in St. Louis. In allo-BMT patients who are not neutropenic compared to patients with acute leukemia who are neutropenic, you can see that the halo sign is more in the neutropenic patients and that the airway invasive signs are more in non-neutropenic patients. And of course, the galactomannan is more frequently positive in patients who are neutropenic than non-neutropenic. This is another example of a patient with acute respiratory failure, severe hypoxemia, but who was very well under non-invasive ventilation. And the nasopharyngeal aspirates identified an RSV, no treatment because it's very high cost, high toxicity, no efficiency. And after 5 days, the patient will be cured with no need for oxygen and only a non-invasive diagnostic and therapeutic management. Another example for viral infection, and this is the true preemptive therapy that has been invented for CMV. And in patients who are recipients of BMT, we are doing PCR to CMV to detect CMV DNA, circulating CMV DNA. And in this case, you can see that it's positive in 30% of the cases. And in this study, 20% of the patients were treated. But what was funny is that overall, only 1% of the patients had a true CMV disease, and half of these patients had a negative circulating CMV DNA, showing very clearly that each time we need to balance between the sensitivity and the negative predictive value of a given test. And this was a very, very hard case. This is a lady having 2 weeks of ICU for pneumonia that was with no diagnosis. Everything non-invasive was negative. We intubated her just for the purpose of doing a BL. Everything in the BL was negative. 10 days after, we said, we are going to do pulmonary biopsy. But before that, let's do a BL again. We intubated her again. She was all the time on an IV. And we redo a BL. Everything was negative. The only thing that was surprising is that she had 70% of lymphocytes in the BL. We say, well, she has maybe a tuberculosis, a viral infection, but nothing was suspected. And we planned to send her on one Friday morning to the pulmonary biopsy, but during the Thursday night, she had blood coming from the mouth. And this hematemesis invited us to perform a fibroscopy, and she had a true esophageal CMV infection with positive biopsies, and under CMV therapy, everything was negative in the BL, in the blood, everywhere, and receiving only CMV therapy, her lungs were cured, but nothing was positive. Only the esophageal biopsies were positive to CMV, and it was very, very hard to believe. But when she was completely weaned from oxygen using only CMV therapy, we understood that she had a CMV pneumonia. Pneumocystis is another very complicated story because we have the huge culture of patients with HIV infection over the two last decades. But in hematopatients, it's slightly different because there is a tight relationship between pneumocystis and the type 1 alveolar cell. And the disease will be with very, very few cysts of pneumocystis, but a huge inflammatory reaction in the alveoli. And these patients are very more hypoxemic, but their BL is most of the time negative. And we can use in these patients PCR. As you can see, we have 448 uninfected HIV patients with a 9% prevalence of PCP, and we were very surprised to see that the negative predictive value of BL of induced PUTA was very close to 100. And we are now using this PCR to say when PCR is negative in an induced PUTA or in a BL, it is saying that we don't have a case of Pneumocystis pneumonia. But of course, we are not using this test to make the diagnosis unless we have a very, very high pre-test probability of Pneumocystis pneumonia. And for example, in a patient with an induced PUTA full of quantitative PCR to pneumocystis with a very high level, and we know it's a CLL with fludarabine, no prophylaxis to PCP, in some of the cases we can consider that the patient is having a PCP. And over the last 10 years, we never had this case again of pulmonary biopsy for a PCP, one very rare trophozoite of pneumocystis, which is no longer the case in my institution. So now we have two different strategies. We have the non-invasive tests combined together and the BL that have, let's say, very close efficiency. And we performed a trial to compare management with or without BL in these patients. In this trial, we included 220 patients, and 106 had only non-invasive tests, and 113 had the BL and the non-invasive test. And as you can see, in both groups, the number of patients without diagnosis was about 20%. And in both groups, the number of patients receiving mechanical ventilation was about 1/3, showing very clearly that if you are not performing BL, you are not decreasing the chances of making the diagnosis, and you are not increasing the risk for the patients of being intubated because of the bronchoscopy. And in 85% of the cases, the BL and the bronchoscopy was done under non-invasive ventilation. And as you can see, the maxi is the group with BL, the mini is the group without BL. As you can see, in both groups, we were able to make every diagnosis and even pneumocystis. And it's very striking to see that in the case of Pneumocystis pneumonia, we had 19 cases here. 15 induced PUTA were positive, not the PCR, but the search for pneumocystis was positive, showing very clearly that if we are doing the test very early after ICU admission, we are making a large number of diagnoses in these patients. And as you can see, the rate of patients receiving mechanical ventilation or dying is exactly the same in the two groups. Another message is that we are in 2012, and after 28 days, the proportion of patients dying with an hematological malignancies and acute respiratory failure in the ICU, we have the patients receiving mechanical ventilation. Mortality is only 30%. We are very, very far from the last decades where these patients were almost all the cases dying. So who could or who should benefit from BL at this time? I think that this is very clear. If you are thinking about drug-related pulmonary toxicity, the only way to avoid having the drug for a patient is to be sure that the drug is responsible for the case. Pneumocystis pneumonia also is a good indication for BL, but only if the patient has never been treated before. If the patient is receiving prophylaxis, I don't believe that the diagnosis of PCP should be kept. And if the patient is already treated since 2 days, it's too late to make the diagnosis. And some say, well, when the patient is intubated, there is no harm of making a BL. This is maybe sure, but if it's not harm, I think this is not useful either. And I think that this is very strange to send the patients to a pulmonary biopsy without doing a BL. I think that we have new diseases that are described, and new emerging fungal infections, and new emerging diseases that are described, and we should use BL for these new types of disease. And I think that for the non-infectious involvement, we should also keep a BL. Let me show you some examples. This is a patient with alveolar proteinosis. It's a patient with a CML, chronic myelogenous leukemia. And as you can see, the diagnosis can be made only by BL, and only if you ask for this very specific color, which is the PAS, that shows that you have some proteins in your BL that could not be seen here with the stars without the adequate coloration. This is the patient I showed you earlier with the hairy cell leukemia, full of eosinophiles, and only BL was able to make the diagnosis. There is no any non-invasive test that is making the diagnosis without if it's not the BL or the pulmonary biopsy. Another way in patients with no hypoxemia is that you can use BL to show that the lymphocytes that you are having in the BL are with a clonal restriction, showing that it is a pulmonary infiltration by the lymphoma itself or by the T lymphoma here in these cases, or T acute leukocytic leukemia. This is another case of drug-related pulmonary toxicity with the diffuse ground glass opacities here, and it will be 100% of lymphocytes, and this very frightening picture is going to be cured after steroids, and only BL was able to make the diagnosis. And of course, you have cases where BL is not useful. You have cases where you have very easy to take biopsies here. Even if you have a pulmonary involvement, you can see here that you have a fusarium infection in the patient with deep neutropenia, that you have a geotrichum infection in this BMT recipient, or all the cases of Aspergillosis. And in these cases, we are not doing BL because we know that we are not with a bronchial disease. We are with an infarction, and we are going directly to the CT, doing a pulmonary biopsy with the CT scan. And as you can see, the patient is lying in prone position, and we are going to make the diagnosis going into the lesion, and it is Aspergillosis. All these patients have Aspergillosis, and all the cases have been diagnosed using pulmonary biopsy using the CT. And this is another way why we should be very open. This patient was with a long-term fever, 2 weeks of fever, nothing was positive, and he has been sent to the ICU because they wanted to do something, because they were thinking that he had something in the lungs. The patient was with no hypoxemia. He had a 100% SpO2 on room air, but the CT was very strange. And look at this very atypical alveolar consolidation, which is in the subpleural area. And we said, well, so we wanted to send the patient to a pulmonary biopsy, and we did the BL, and the only thing that was positive was PCR to pneumocystis. And we say, well, this is not pneumocystis pneumonia. And at the same time, our colleagues from Taiwan published exactly the same case with a very atypical nodule. And in both cases, it was granulomatosis pneumocystis. And this very, very difficult case need all of the time pulmonary biopsies, because otherwise we are not able to understand what is ongoing. And the patient was completely cured after cotrimoxazole therapy. And we really need to keep it very, very open-minded, otherwise we are going to fail. And some others have very, very good hands and can perform a transbronchial biopsies to perform a diagnosis here of pulmonary aspergillosis. I'm trying all the time and I'm failing all the time, but some are better than us, and it's very funny. This is Vincent Ninan in Brussels. He has a huge transbronchial biopsies experience, and sometimes it's very, very complicated, and we are dealing with a disease which is related to a toxicity of chemotherapy. This is the veno-occlusive disease in a patient recipient of an autologous BMT. And the only way to make this diagnosis of occlusion is pulmonary biopsy. There is no other way, and we should keep pulmonary biopsy also for 1 to 5 times a year, but we should do it anyway. Thank you very much.